Okay, the next presenting author would be Dr. Stuti Chand, study of conjunctival flora in patients undergoing cataract surgery in a tertiary care hospital.
Good evening, everyone. I'm here to present the study of conjunctival flora in patients undergoing cataract surgery in a tertiary care hospital. Postoperative endophthalmitis is one of the most devastating complications of intraocular surgery with grave visual consequences or even loss of an eye, with incidence being maximum following a cataract surgery of about 0.82%, followed by secondary IOL implantation, glaucoma surgery, pars plana vitrectomy, and intravitreal injection in descending order. The aim of the study was to isolate and characterize bacterial and fungal flora from conjunctival sac of cataract patients presenting to a tertiary care hospital, and also to analyze the effect of seasons and age on the growth pattern of the flora inhabiting the sac. Our study was cross-sectional observational study in patients visiting IOPD, and 320 eyes were included in the study over a period of 12 months from December 2016 to November 2017. Study period was divided into 4 seasons: Season 1, Season 2, Season 3, and Season 4. Season 1 was winter with temperature of 10 to 15 degrees Celsius. Season 2 was summer with temperature 32 to 40 degrees Celsius. Season 3 was monsoon with temperature between 20 to 30 degrees Celsius, and Season 4 autumn with temperature 25 to 35 degrees Celsius. Three conjunctival swabs were obtained from patients diagnosed with cataract in either or both eyes and sent for culture via chocolate and blood media, Robertson cooked meat media, thioglycolate media, subblood dextrose media, following QH mount. The study eyes were divided into 3 groups as Group 1, which comprised of eyes of patients aged 18 to 50 years. Group 2 comprised of eyes of patients aged 51 to 65 years, and Group 3 comprised of eyes of patients aged above 65 years. All the patients attending to IOPD of more than 18 years were included, whereas patients with infectious conjunctivitis, corneal ulcer, contact lens wear, patients on topical anti-glaucoma drugs, topical or systemic antibiotics were excluded. The outcome was measured on the basis of aerobic and anaerobic bacterial flora as well as fungal flora growths, which were identified on culture media. The correlation of seasons and age with growth pattern of the flora was also done. The conjunctival swab from 242 eyes showed growth out of 320 eyes, and out of the swabs which showed growth, 67.50 was gram positive, 7.18 was gram negative, and 0.93 was fungal positive. The organisms that were isolated in culture was maximum with Staph epidermidis, which was about 35.01%, followed by Staph aureus propionibacterium species. Correlating age with growth, the growth of organisms was seen maximum in age group. In Group 2, with consist of age between 51 to 65 years, and among this, Staph epidermidis was seen to be the highest in number. Correlating growth with seasons, the growth of organisms was seen throughout the year, and the findings in all 4 seasons was not statistically significant, whereas the variation of prevalence according to the season was seen maximum with was seen maximum in Season 1, that was between 10 to 15 degrees Celsius temperature, with gram positive being the highest in number. Discussing briefly about normal conjunctival flora, eyelids and conjunctiva harbor a significant number of bacteria and occasionally fungi, and these are the normal flora that secrete antibiotics. These act as chemical mediators. These maintain surface homeostasis and immunoregulation. These are not infectious under normal circumstances due to secretion of bacteriostatic substances, and they reside in decreased temperature due to evaporation of tears, exposure, and less blood supply. The range of conjunctival flora varies with genetic makeup, nutrition, age, sex, race, immunosuppression, ocular inflammation, dry eye, contact lens wear, antibiotic use, and surgery, external exposure, climate, and geography. The microbial flora of normal eye is the most common predominant is gram-positive cocci, which tops the and Staphylococcus epidermidis tops the list with 30 to 90%, followed by Staphylococcus aureus, Micrococcus, and other common cells of conjunctival flora are gram-negative cocci, which Moraxella cataralis, Corynebacterium species, Haemophilus influenza, Klebsiella species, E. coli, Pseudomonas aeruginosa, Moraxella species, and among anaerobic organism, Propionibacterium species is the common. With increasing age, gram-negative organisms also become part of the flora. The most common organisms responsible for post-operative cataract surgery endophthalmitis is also Coagulus negative Staphylococci, with Staph epidermidis being 70%, followed by Staphylococcus aureus, Streptococcus species, Enterococcus, and gram-negative bacteria, Propionibacterium acne, and lastly fungal. Endophthalmitis after cataract surgery is a severe complication, and Staph epidermidis have a better prognosis than Staph aureus. The important risk factors that are responsible for post-operative endophthalmitis are old age, diabetes, intraoperative risk factors such as post-capsular rupture, combined surgery, prolonged surgery, post-operative wound leak, vitreous incarcerated in wound, other than preocular tear films which act as host to several organisms, respiratory flora of surgeons and assistant, ambient air, and surgical instruments and devices, including IOL irrigating solutions, act as source of infection, and evidence-based prophylactic measures, including preoperative instillation of povidone iodine drops, can help us to prevent post-operative endophthalmitis. To summarize, the pathogens causing endophthalmitis are mainly indigenous bacteria from sites on the ocular surface, such as conjunctival eyelids and meibomian
Please
glands.
sum up.
To conclude, conjunctival swabs as routine preoperative investigation can identify flora likely to cause post-operative endophthalmitis, and thereby they help in implementing preventing measures accordingly. And the role of preoperative conjunctival swab is mainly important in high-risk patients in diabetes, immunocompromised, contact lens wearers, and one-eyed patients. This may be included as a part of routine preoperative workup of patients if resources permit.
Thank you, Dr. Stuti. So what is the aim of this study? You said you wanted to study, you have studied, you have found some important things. Maybe all of it is not new, but still you did a good job. So what was the aim and what do you recommend? Because this is the most important thing that we ophthalmologists do day in and day out.
Yes, the patient many times the patient with post-operative endophthalmitis, the organisms causing post-operative endophthalmitis could not be known. So taking conjunctival swab preoperatively and isolating organisms can help us to find out the organism responsible for post-operative causing post-operative endophthalmitis.
So, sir, madam, are you recommending that you do conjunctival swab test for every pre-op patient?
If resources permit, we are emphasizing to do the conjunctival
I don't know how
swab.
many people are doing it.
It's a very contradictory statement.
No, but the thing
You know,
is,
it
when
is-
you say
we used to do it.
you have gotten a swab.
All of us have left it.
We have left it because preoperatively we are
How
giving
many of you in
probably
your
antibiotics,
institute follow this? You see so many young
Preoperative.
people, most likely
And
working
it
in
turns out-
different places. You use conjunctival swab only in one eye. Any other?
both.
Sir, we have got our very esteemed chief of the RP center. Sir, what do you recommend? She's telling that it's
Practice has been left for almost 2 decades now.
20 years.
Yeah.
That was when we started.
Consultatory evidence that conjunctival flora is cause for endophthalmitis.
They reside there. Yes, sir.
What we culture may not be same unless we do a genetics of those bacteria. I can't say this is the bacteria which is causing infection. So that is the point. You might culture staph and staph, but that staph may not be the same staph. That is the important part.
No, but the thing is, you said when you got on a culture positive, then what was something? How many days I mean, what was a precautionary measure? What antibiotic you used it? Whether the
How many days
sensitivity,
after the test
and
you
then
are-
after that, how many days after that you repeated the swab and then did a surgery?
So we did not
Because
repeat-
that was not mentioned into that. Because
Yes, sir,
once you have a culture positive, whatever, I mean, even if it's an epidermis, but still you can't operate because you have a report positive with you.
So actually, it is a cross-sectional observational study. So we did not follow the patient after cataract surgery.
Okay, it's a good beginning to study. You learn methods, but I think you have to do it further, take it further.